Um, so we work on these policy issues, bringing the voice of business people together to make the business case for why healthcare reform and other issues that we work on are really beneficial to the economy. So this morning we have a series of speakers that come from the private sector, also have worked in the healthcare industry extensively, and wanted to educate you all about what Section 2706 is, and then how you can become more involved in advocating for compliance with the law as it now stands. So with that, let me turn to my colleague, Alyssa Worstrel. And Alyssa is the Executive Director of the Integrated Healthcare Policy Consortium. She's based in California, and IHPC is a member organization of the American Sustainable Business Council. And Alyssa, I'll turn it over to you.
Thanks so much, Richard. Glad to be here today. We're very proud to be a member of ASBC and to be connecting with you all today about this important topic, which actually affects employers, insurers, employees, practitioners, consumers, patients, the whole gamut. So I want to give you a little bit of background about IHPC. We are a nonprofit 501c4. We were created at the recommendation of legislators to represent the consensus voice of complementary and integrative healthcare on the Hill. And we're a consortium of national associations and educational and research organizations representing licensed professions of integrative medicine, acupuncture, midwifery, holistic nursing, naturopathic medicine, chiropractic and massage therapy, as well as homeopathy on policy and advocacy issues of national concern. You can go ahead and go to the next slide, Marvin. And yeah, there you go. So we represent over 400,000 patients, and we like to say by extension millions of patients in the work that we do, which includes things like congressional briefings, federal agency testimony and commentary, legislative action, both on a state level but mainly federal, issue-focused campaigns, policy conferences, reports and unique publications, and more. And in terms of the Affordable Care Act, IHPC is responsible, along with others, for the inclusion of 7 points of legislation in the ACA in support of integrative healthcare. And I'm going to talk just briefly now about one of those provisions, which is Section 2706, drafted by Senator Tom Harkin, who's now retired, with support from IHPC and others. So what's the issue with 2706, or what is it about? Health insurance companies frequently refuse to contract with insurance healthcare practitioners, which keeps them out of insurers' provider networks. And this exclusion does two things. One, it prevents licensed providers from delivering their services on a reimbursable basis. And two, it prevents members of health plans, who are patients, from being reimbursed when they choose those providers. So this discrimination actually increases the total cost of care for individuals or for individual patients who pay out of pocket for access to integrative health services, which has been the standard practice, mostly paying out of pocket. So while Section 2706 is designed to protect providers from being excluded from healthcare plans, it also provides patients greater access to the providers of their choice. And Section 2706 also, for congressional intent of 2706, also allows for more access to licensed care from patient demand and selection, which will result in better treatment outcomes, which will lower the cost of care when integrative health providers have equal standing in the integrative financial system. So that's the good news in a nutshell. And the bad news is that Section 2706 has not been properly implemented on the state level in 2014 when the state health exchanges went live. You can go to the next slide, please. So various organizations are having some success with working with insurance commissioners, advocacy efforts focused on interactions with commissioners while other states are employing legislative remedies. And Cover My Care, which this slide shows a screenshot of our site at covermycare.org. It's our campaign to bring awareness to all of the efforts on state level around Section 2706. So you can check that out, where you can see which states are active around 2706 and to access the resources that are available to take action on a grassroots level. There's a toolkit on that site for both practitioners and for patients. And this is just a partial screenshot. That's actually, that site has a lot of depth to it, so I welcome you to take a look at it. The next slide, please, which is the final slide. Okay, so we like to say that it's an urban myth that integrative care is more costly to the bottom line than conventional care alone. We know that, and data actually bears this out, that patients who work with integrative health and medicine practitioners are healthier, have lower healthcare costs, and report extremely high levels of patient satisfaction. And to that end, and to illustrate that objectively, IHPC has compiled a 16-page booklet, which is on the lower left of your screen, titled Integrative Health and Medicine, Today's Answer to Affordable Healthcare, Health Creation Economics, a compilation of scientifically compelling current data showing the cost benefits of integrative care. And that's available also on the IHPC site, which is at ihpc.org, and welcome you. It's also at covermycare.org, but I welcome you to check that out and download it and use that as a resource as well in your conversations. It was meant to be used as a tool with the audience of policymakers, legislators, insurance executives, and others to dispel this quote-unquote urban myth that integrative care is more expensive to the bottom line when actually the opposite is true. So thank you very much for your attention, and now I am going to introduce our first speaker, who is Dr. Wayne Jonas. Wayne Jonas is the president and CEO of Samueli Institute. He's a widely published scientific investigator, a practicing family physician, professor of family medicine at Georgetown University, and adjunct professor at Uniformed Services University of Health Sciences. Additionally, Dr. Jonas is a retired lieutenant colonel in the Medical Corps of the United States Army. Dr. Jonas was the director of the Office of Alternative Medicine at the National Institute of Health, and prior to that served as the director of the Medical Research Fellowship at the Walter Reed Army Institute of Research. He is a fellow of the American Academy of Family Physicians. Dr. Jonas.
Thank you very much, Alyssa. I hope you can hear me.
Yes.
Just wanted to say a few words about our experience in looking for evidence-based solutions using, drugless self-care integrative approaches, and some of the focus that we've had on working with large organizations, the two biggest ones being the Defense Department and the VA, but we work with a number of other organizations, and I'll illustrate that in a couple of my slides. Next slide, please. Just a little bit about the Institute. We're a 501c3 nonprofit, been around since 2001. Our focus is on what I call salutogenesis, which is the creation of health. It's the flip side of pathogenesis, the treatment of disease, and when we talk about integration, we talk about integrating a health and healing approach with disease treatment approaches. Both. If you build your healing capacity, then you can often avoid more expensive treatments and improve performance. Next slide, please. We work with research, innovation, and educational components, individuals, organizations, and communities. I'm going to focus primarily on organizational change because I believe the business groups that are listening to this webinar have an interest in that. The goals of all of these aspects, the salutogenic or the health creation model, is to improve performance, achieve and maintain wellness, and reduce chronic symptoms and improve function. So next slide, please. So I'm going to talk a little bit about evidence because we start all of our approaches with organizations grounded in the evidence, and we have a very robust system for determining the evidence and then looking at how do you customize it to the needs of the organization that is trying to implement some of these areas. We use state-of-the-art systems like Institute of Medicine, the Cochrane Collaboration, for those that have heard of that, and HHH agencies like AHRQ and others. But what we've done is automated this process. I started this when I was at NIH for complementary medicine, but we've now markedly enhanced it, and I'll show you several examples of that. Here's one example that's recently come out last year. This was a comprehensive review of self-care therapies for chronic pain, in which we were looking at what is the evidence for the effectiveness of self-care approaches like yoga, tai chi, music therapy, etc. in these areas. We did this for the DoD VA Task Force on Pain Management. As many of you know, not only the DoD, but the country has a major problem with how we approach pain. The Institute of Medicine said in 2009 we need a cultural transformation in these areas, primarily implementing more self-care and integrative practices in these areas. We haven't done that very effectively, which is why we now are having more and more problems with opioid epidemics, addiction, and increased death rates and problems with that. So this is starting with the evidence. We previously looked at acupuncture for the Defense Department using evidence approaches, and the result of that is that the Defense and VA are now rolling out acupuncture in all of their sites, both training individuals in simple acupuncture techniques like battlefield acupuncture, but also training their healthcare practitioners in acupuncture. One of the challenges that they have found is since TRICARE and the Defense Department do not cover acupuncture, then 2706, if it were to be passed, would help them to be able to hire and reimburse for that. Next slide, please. Here's another example, and I put this one in, of a research and evidence component specifically in the area of resilience and performance. I put this one in because I know many of the companies that are working here are particularly interested in performance enhancement, and I'll show you some examples of companies we've worked with around performance. That, needless to say, is also of interest to the DoD. Next slide, please. Next slide, please. We've also focused on nutritional components, a very important aspect of performance. Here's an example of a joint evidence evaluation for omega-3s. These are healthy fatty acids and have demonstrated, this was done with the NIH and with DARPA, to really look at what's the impact of omega-3 and omega-6 intake on brain function, as well as recovery from trauma and performance enhancement. And I'll show you how we've used this and other evaluations of nutrition and brain function around performance in a minute. Pardon the noise in the background. I don't think there's anything I can do about that. Yeah, next slide, please. So here's an example I thought I would show as to how we work with organizations to help them implement this in their own culture. This is a framework called Optimal Healing Environments. It was developed by literally hundreds of patients, practitioners, healthcare organizations, and scientists to really put together the components of what the evidence says works for health and health enhancement. It has 4 domains: internal, interpersonal, behavioral, and external environment. And this framework is helpful for getting everybody in the organization on board around a similar language and beginning to track those elements as that they go in. Next slide, please. So one of the ways we do that is by doing a survey, and what we call it the 360 Optimal Healing Environments Inventory. And we go in and basically biopsy the organization in terms of looking at what they're doing to enhance performance and healing in their own practice. You do that from the C-suite on down to the workers on the floor, and you get a sense of the cultural penetration of the things that they're already doing. And this gives you a great starting point. It shows you where your strengths are, it shows you where the gaps are, and it helps the entire culture move in a positive direction around health enhancement. Next slide, please. This also provides a tracking tool. Here's an example of a hospital that used this approach, the OHE assessment, 300-bed hospital down in Florida. They adopted this framework and began to implement it in their strategic plan. And within a year, they had significant improvements in staff engagement, patient satisfaction, and the ROI was significant. Their operating margin improved by 5.5% in the first year. Next slide, please. Here's another example. This is a hospital in New Jersey that implemented it, increased their operating margin by 9.6%. As it turns out, the major driver of their cost was nurse turnover, which it is for many hospitals. The nurse turnover for other hospitals and them when they first started this was over 7%, and they were able to have that, saving them over $2 million. Next slide, please. Once an organization is interested in this and they've gotten a biopsy of these areas, then we also then offer some leadership training, again, to get your entire culture thinking about health enhancement and performance enhancement. One has to have a common language within the organization, so we'll provide leadership training in these areas. Here's an example of one we're doing at Fort Belvoir Community Hospital with 120 leaders in that hospital down there. That involves didactic, experiential, as well as gives them specific tools. They come away from that exercise not only with personal things they can do to enhance their own health, but also leadership and organizational action items that they can take on Monday to begin implementing that in their organization. Next slide. For those that then want to go on, then we can then take and customize the needs of that organization to implement it across and spread it across to the workers, so it's not just a leadership component. This usually involves a curriculum, but not a health promotion curriculum in the same sense that you get with a worksite health promotion program. This is customized to really address the cultural components using the OHE 360 tool. Here's one that we did for Google, out in San Francisco. They were particularly interested in the nutritional components, so we designed with them a 5-component behavior change health enhancement program that involved culinary arts, nutrition, exercise, mindfulness, and health coaching. They're in the process of now rolling this out on one of their campuses, and then we'll look to spread that after they've adapted it. Next slide, please. Similar kinds of approaches we've taken in the military to optimize performance there. Here's 2 examples. One, the culinary components on the left side of this picture. This is being done with some of the experts across the military who procure and research in these areas. They're learning about nutritional cooking components in those areas. We have a project called Metabolically Optimized Brain, in which they're coming together in December now to decide on food purchasing. On the right-hand side is the medical students at the Uniformed Services University engaged in a yoga practice to help with stress components, so they have some first-hand experience. These are future military doctors here. Next slide. Worksite wellness is something that's very popular right now. It usually comes through HR departments. What we've found is that it's a great effort to work on, but it generally doesn't or often does not penetrate into the culture as a whole. Recent RAND evaluation of worksite wellness programs around the country demonstrated that this was the major problem, was penetration to the culture. And so using these kinds of cultural change projects I just talked to you about are the next step beyond that for work sites that want to engage these across their cultures. Next slide. Finally, to really change the culture and change the effort, there needs to be collaboration across multiple areas and multiple programs. Frequently, we find that some of the practices that healthcare groups want to implement are just not available. Again, the importance of 2706. and it's a passage. But also there needs to be more than that. Next slide, please. And so one of the things that we've been doing is developing continuous improvement efforts, or helping organizations into their quality improvement processes, their normal quality improvement processes, some of the practices that the evidence demonstrate work and will help them. So the way we've been doing this is by partnering with an organization called the Institute for Healthcare Improvement. They're developing what they call breakthrough collaboratives. These are essentially learning networks that allow the PDSA cycle, or the testing cycle in a quality improvement program, to uptake some of these practices and begin to make the changes in the system necessary to actually make them stick. So they're not just dependent upon a champion who happens to be there. These collaboratives can be done within a large organization like the Google or DoD. They're doing them, or they're done between organizations. We've just finished one on chronic pain, an important area not just for healthcare organizations but also for work sites, because chronic pain is one of the most expensive things, not only in treatment of chronic pain but in reduced productivity. And so we're planning a chronic pain collaborative. We're also developing one in palliative care, end of life. Next slide. So those are the end of my comments. I hope this helps you look at some of the organizational change components and how these kinds of practices can be brought in. Thank you very much. Next slide. I want to introduce the next speaker. This is my friend and colleague, Dr. Kent Bradley. Dr. Bradley is, one of the leaders in the country in terms of health and health enhancement. He currently runs a BTN Advisors, an innovative health technology support company. He's well qualified to help how to make an end of Safeway Health, helped with early stage health benefits, has also served as Senior Vice President and the Chief Medical Officer for Safeway. His leadership skills at Safeway were honed over a full career in the military, where he was a distinguished leader, graduate of the U.S. Military Academy, also receiving MPHs and MBAs. Currently, doing your time.
Thanks, Wayne, and wow, I appreciate that intro. I just wanted the audience on the line to talk a little bit about my experience. The evidence, as Wayne has laid out, is obviously there. I think there's a great interest within the population, and so when you talk to actual individuals that are seeking health care, willing to pay out of their pocket for services, they find value in it. And I because when I came to say I need to treat a person holistically. With that in mind, one would assume that you would have more freedom in the health plan, and that is you're large enough and with smaller as an acquisitions are happening, and they get 100, 200 pages of documents to see what covered and not covered. covered under their CPT code of 99214. But if you wanted to go see an acupuncturist who spent their entire career focused on acupuncture, you could not see them. So there becomes this interesting dichotomy between what aware of. The other thing that I began to realize is that because employers are finding ways to provide this outside of the health plan. And so for us, we find a lot of these integrated health solutions at the military treatment facility, yet they aren't able to embed it because of policy in the health plan called TRICARE. So just like we weren't able to embed some of the services in our health plan, we offered it at our Pleasanton campus. So we had yoga provided for free, we had meditation, and we were able to increasingly provide services in a direct primary care model. The focus of my few minutes, I wanted to just highlight a policy conundrum where you see the demand that is there by the person who is trying that meets their needs. You see this growing body of evidence that a holistic approach clearly must embrace integrative approaches, and yet this disconnect between health plan coverage and how it is stipulated based on the type of service and who provides it. Whether a neurologist can provide acupuncture better than an acupuncturist is debatable. So I think those are areas for us to have a discussion around and really focus our attention as national organizations and thought leaders. I'm happy to answer any questions in the Q&A about Safeway, my experience in other arenas, but of the time of the audience. With that, I'd like to just transition to John, who's, the irony here is that I was based in Pleasanton, California, but I lived in Fort Collins, Colorado, where I've had the pleasure of going to visit New Belgium Brewery, and they truly have a progressive culture that is, I'm excited to hear John's story. John is the Human Resources Director at New Belgium, and he's responsible for, as it says on the slide, everything to do around human resources. And I can tell you that they have a wonderful culture, to the point that Wayne had said, penetrating the culture is critically important, and I think they've done that in spades. So with that, John, please continue on.
Thank you, Dr. Bradley. So our experience, so just like I said here, if you just want to go on to the next slide, please. So just a little bit about us, New Belgium Brewing Company in Fort Collins, Colorado, and thank you for those kind words, Dr. Bradley. We really appreciate that. So we're the fourth largest craft brewer in the United States, and as Dr. Bradley mentioned, our core values and beliefs, our culture is one of our critical pieces to us, and we've worked very hard to grow that and to maintain that. When we were started back in 1991 by a husband and wife, and the wife happened to be a social worker, our goal was to be a business role model and to not only make great beer and be successful, but to support our culture and our coworkers. A couple of our cultural values and beliefs that are relevant here. One is kindling social, environmental, and cultural change as a business role model, and also balancing the myriad needs of the company, our coworkers, and their families. And so, as we've grown over the past 25 years, now we're well over 670 coworkers. We're in 39 states. We've tried to keep that ideal of supporting got involved with these type of alternatives. It's not so much from an ROI or a reduction of healthcare costs, but from a meeting of our coworkers' needs. So if you go to the next slide, please. And so our focus has been on that piece. We have on the Maslow's hierarchy of needs piece. You can see here just a graphic display of that, and we feel that if we meet our coworkers' basic needs, then they will be more productive, they'll be more healthy, and better overall for us and them and the families. Intentional, systematic, long-term humanized way of thinking, and sometimes we've taken things to, we've had swings and misses, we've explored, we've looked at different alternatives to make sure we can do the best overall. As Dr. Bradley talked about, we are self-insured. We've been self-insured for about 15 years. We became self-insured probably earlier as far as coworker population than some employers, out of a desire partially to make sure we had that type of control type of services and benefits that we provide to our coworkers. As Dr. Bradley mentioned, it's extremely important to understand what services you want to provide it to make sure that's, and so that was our reason, rather than taking what a TPA would give us and say this is how it goes, we were designing those documents to make sure they met our needs. And so next slide, please. Excellent, thank you. So, back, please. More to clinic coworker, and as for example, we had started a wellness clinic last year, and we were very intentional about having a doctor of health needs and a broad varied alternative medicines as that was needed. Next slide, please. So as far as the topic here, we talked off, we primarily started, we dipped our toe with these kind of integrative health and medicine options with acupuncture. We had requests from our coworkers, medicine for life, etc., were more effective. Some of the things that earlier speaker spoke about, as far as, you know, ways to provide them to our coworkers, added any additional, and we didn't significant costs, and sometimes they were, we found our experience was they might be cost mitigating. I don't know that we've ever done a study and gone deeply enough to say that they were cost savings, but we certainly felt they were worthwhile investment. And we wanted to embrace that holistic approach that our coworkers were taking. So we went into the we started providing coverage for acupuncture. We got a lot of positive feedback about that. Then we added naturopathic services. And then about the same time, we were looking at smoking cessation, and we had some really good requests and outcomes for hypnosis as an alternative medical writer to our plan, and that was just in 2014. And then the most recent addition we've had is rolfing. And we've looked at the parameters of the coverage, making sure that the provider had the required licensing, et cetera. And then the goal was, again, giving our coworkers an option for the different treatments as our coworker population aged and had these different needs. So that's kind of basically where our story is, and our experience was that not coming out of a business need or a desire to reduce costs, but coming from the perspective of honoring our coworkers, their needs, and meeting them where they're at. So hopefully that experience will help you all. If you have any questions, be happy to answer those. And the piece there is don't be afraid to take a swing and a miss. See what you can do out there and do good things. Thanks.
Okay, great. John, thank you. Richard Idlin here again. So what we'd like to do with the remaining time is take some questions from you all. And before we get to that, I'd encourage everyone to take a look at the American Sustainable Business Council's website. And under Actions, we have a page that relates to this healthcare initiative. And so, again, you know, our objective here is to engage and mobilize healthcare practitioners, business people, to be advocating for change in state legislation, because, you know, there's not much the federal government will probably do at this point. This is really now up to the states and insurance commissioners in those states. So I'll just quickly note that in 2 states in particular, Rhode Island and Oregon, the governors of those 2 states have taken pretty aggressive steps to ensure that the insurance commissioners require healthcare providers to include CAM within the coverage requirements of healthcare plans. So that's what we'd like to see in all 50 states, that all states are now really actively complying with the law. And what we have found is that because of the complexity of the ACA, things not going right in all cases with the sign-up program, that the implementation of Section 2706 has not been the highest priority for all state insurance commissioners. So our job is to both educate insurance commissioners about the value, and as John just pointed out, the economic value and the demand among workers in the economy. And then secondly, to get governors and if necessary state legislatures to really push for the full-scale adoption of the law. Alyssa, do you want to say anything else about the campaign we're working on together?
Sure, yes. So yes, everyone, if they can take a look on the ASBC site, I appreciate that, Richard. And thanks for mentioning what's happening in Rhode Island and Oregon. Those are 2 good examples of legislation that went through that is specific to Section 2706 language on a state level that got fast-tracked through their previous legislative session. There's also interesting activity in the state of Minnesota, where IHPC is working with a multidisciplinary coalition to also bring language to the 2016 legislative session that is similar to the federal provision of Section 2706, but includes an enforcement provision. And that's one of the problems with the federal provision, is that it lacks an enforcement, sort of an enforcement piece to it. So, which is one of the reasons that we're having difficulty with the implementation, because of this lack of enforcement ability. So, so take a look also at covermycare.org in the state section, so you can see what other states are up to and what your state is doing for around activity at a grassroots level with Section 2706. And I also want to recommend that you do access the toolkits that are available to you through covermycare.org, because there are letter templates available in those toolkits that you can use to write to your commissioner, to reach out to your various representatives about Section 2706, either as an individual or through coalition activity in your state. And also feel free to contact covermycare.org. Taylor Walsh is our project director. His contact info is at covermycare.org, or reach out to me through the IHPC site or through ASPC for more information. And we'd be happy to provide you with more detail and more resources. And we're working closely with ASBC through this into 2016 on this important issue. So really appreciate the support, Richard. And if anyone has any questions, please bring them forward.
Okay, great, thank you. And I just want to point out that, because there was a comment, maybe somebody didn't understand, that New Belgium Brewing is a business, is a member of ASBC, and the reason that they're on the phone is to give a real life example, like we heard about Safeway, of companies adopting these kinds of practices. So just before we go forward, I'll also note that Minnesota, California, Hawaii, New Mexico are also working on legislative initiatives in 2016 to require enforcement of the law. We have a few questions, and Marvin is going to moderate that.
All right, Camille, you should be able to speak now.
Hello, thank you so much. This is Camille Leon, founder and executive director of one of today's sponsors, the Holistic Chamber of Commerce. I just want to say thank you so much to all of our wonderful speakers and our co-sponsors today. This is invaluable information for letting everyone know, business and consumers, that the U.S. and our national policy is starting to turn the corner so that holistic, integrative, and complementary medicine are covered by our insurance companies, and let anyone want to go holistic professionals and practitioners who can help you while you are trying to get your insurance company and your employers to also offer this extra coverage. We're headed in the right direction, everybody, and it's wonderful to be partnered with the ASBC and IHPC on this kind of education and awareness and advocacy efforts. Thank you.
And we also want to announce that Camille and the Holistic Chamber of Commerce are new ASBC members. So we're happy to have those folks on board. Next, we have a question from Andrea Beth. You will be coming off of mute in a couple of seconds here. There you are, Andrea. Can you hear? You're off mute now, Andrea. Okay, so we will read off her question then. I am an acupuncturist in San Diego. Since the enactment of the Affordable Care Act, what we are seeing here is that insurance companies are reducing compensation for services. One of the ways I see this is that we are no longer paid for performing the exams that we are required to do. Prior to ACA, we were paid to do these exams. Now insurance companies get around this by stating that the exam is included in the treatment visit. What can be done about this? I believe this is contrary to the intent of Section 2706. My chiropractic colleagues tell me this new standard is not being applied to them. So any one of our panelists want to take a stab at that?
This is Alyssa. Yeah, I'm sorry to hear that's happening, and I'm not surprised. I think it's another example of the inequities of the system, and dare I say, the loopholes available. I don't know if it directly applies to 2706, but I do think that your intuition that it does apply to the congressional intent of 2706, which is protective of practitioners and patients alike. Practitioners in terms of discriminatory practices against them and exclusion from health plans or discriminatory practices when they're in the health plan network, and also for patients in terms of having access to those practitioners. So, and having said that, I mean, I just do want to say that, you know, the conversation around discrimination, using the word discrimination is a little bit loaded, just because it's still a very privileged conversation that we are having about access to care when there is so much baseline inequity in terms of access to care in the United States just at large. So, you know, IHPC wants to be sensitive to we also want hard baseline. But as it turns out, it's about this within insurance.
Okay. So we have here, if you want to.
Okay, can you hear me?
Yep.
Great. I'm the project director for Cover My Care, so I've been dealing with folks in the states who are taking the initiatives to formulate legislation, often because the federal Section 2706, as someone has mentioned, Alyssa had mentioned, does not come with enforcement or any penalties. So we're seeing interesting dynamic in the states where the state health regulators access and the work of providers in the states is copying, if not the language, then the intent of the federal law. So we're seeing Minnesota, but also California, Hawaii, and New Mexico, at least, are preparing similar bills for 2016. They were passed in Oregon and Rhode Island. The problem is that things are inconsistent all over the country. I'm sure a lot of folks know that you can cover up to a point. It depends on the state. It depends on the plan. But it's extremely inconsistent. And this is why it's important for employers to understand what Kent, for instance, learned at Safeway, and John as well, that the value that is expressed by employees for access to, in fact, not cost accumulative, but can be cost. We have, as Alyssa pointed out, is published a booklet on that brings together research on the cost of therapies. I recommend that visitors folks take a look at that if you would like to get an idea of costs. These are therapies. So, and if at the states, based on coalitions that are in formation, please drop me a Thanks, Rich.
Okay, and so if there are no more hands have been raised, speaking, but if you're having
So Taylor and I and Alyssa will back in touch with you all shortly. Some other states we're going to go to down
together to support Section 2706 related activity and just taking it on. So we're trying to, be that clearinghouse, central clearinghouse, so that people can log in and stay current. So likewise, if you new act, please bring it to our attention. We try and stay current so that so we can perform that function well. And I would just leave with that.
Of the day. Thank you.
Awesome. Thanks.
Thank you.
Bye.